Good afternoon, ladies and gentlemen. My name is Isadawong, a fifth-year medical student from College of Medicine, Rangsit Universities. I'm here to present my studies on assessing the comparative effectiveness of psychological intervention for patients with post-traumatic stress disorders after disasters, a two-stage approach network meta-analysis. So, as you know, the trend of the disasters has been increasing globally in recent decades in both man-made and natural disasters. Post-traumatic stress disorder is highly prevalent mental health condition among individuals affected by disasters. However, uncertainty persists regarding the relative effectiveness of various types of interventions for treating post-disaster PTSD. So these are our study objectives. First is to examine the effectiveness of intervention for treating PTSD symptoms in patients affected by disasters, and to investigate the potential effect modifier that may influence the effect size. So we use this standardized mean difference in our studies. So we systematically search in Scopus and PubMed for randomized control trial of the psychological interventions for post-disaster PTSD, then conduct a pairwise meta-analysis and then MMA. Here's our inclusion and exclusion criteria of our studies, with inclusion criteria being the only randomized control trial with intervention aimed at treating post-disaster PTSD. And we only including paper reporting the outcome that relating to the PTSD severity scores through the effect size can calculate the standardized mean difference. So here's our PRISMA flowchart. So as you can see from our flowchart, the 6,655 records were identified after our exclusion criteria. We include overall 36 studies in our analysis. So the table 1 demonstrates the baseline characteristic of each included studies. So for the man-made disasters, the overall is 55.7 and female is 44.3. And you can scan for the QR code here to see the full table. We then perform the quality assessments of the studies by using Cochrane risk bias tools. On the left-hand side is traffic light figure diagrams, which depict the risk of bias in each domain of each included studies. So let's take a quick look at our meta-analysis result. So as you can see, the forest plots show the overall psychological interventions can reduce the post-disaster PTSD symptoms. Next, we did a subgroup analysis by the type of the disasters and the type of the interventions. The results show that the interventions are effective for both man-made and natural disasters. When compared to the control groups, all interventions were shown to reduce the PTSD symptoms, similar to the overall analysis. Then we also assessed the small study effect or bias in our studies by evaluating the frontal plot. We found some small study effects and explored the source by conducting the control-enhanced frontal plot. And the plot suggests that the small study effects within our study are not due to the publication bias, but it's probably come from the heterogeneity within our studies. Now, let's move to the main result from our network analysis. So, as you can see, from our network structure models based on our studies, we have grouped the different types of the intervention based on existing evidence and including studies. The network map models comprise of the 6 nodes. Each node represents an intervention and direct treatment comparisons, and their size are weighted according to the number of the study for each intervention. And the number on the line indicate the number of the study for each direct treatment comparisons. So as you can see from our network visualization for all consistency models. Then we also conduct a network forest plot to rank the different types of the intervention. So as you can see, there are 5 interventions, not including the control node. The ranking score by the surface cumulative ranking curve or Zucca values are shown on the right-hand side. And as you can see, EMDR appears to be the most effective interventions, followed by exposure therapy, group therapies, CBT, and lastly is alternative therapies. We also conduct the comparison at the frontal plot to assess the small study effect of our network models. The results show that there's no small study effect of overall consistency model in our studies. So we have also repeated the network map and to do the subgroup analysis by type of the disasters. This is the network map from the subgroup analysis. Then we also repeat the network for report to rank the intervention by type of the disasters. For man-made disaster, the result is quite similar to the overall analysis. But however, if you look at the national disaster, the results are inconclusive due to the limited number of the study for each intervention. And this is the Zuka graph, indicated the x-axis indicated the ranking number, and the y-axis indicated the probabilities. And we also repeat the comparison adjustment report, and the result is very consistent with overall analysis. So, in conclusion, our study suggests that EMDR is the best method for treating post-disaster PTSDs, but alternative treatments are also effective. So clinicians should consider this finding when making patient care decisions to optimize mental health support for disaster-affected population. Additionally, global health could be prioritized evidence-based EMDR for community resilience against PTSD patients by integrating these findings into the treatment guideline or disaster response. Or even with the intervention with proving the efficacy, we can also make significant strides in mitigating the PTSD symptoms and promote the overall well-being in aftermath or any traumatic events in medical societies. So this could be applied to the small to the large scale in terms of implementation. So let's have a quick look at our limitation. So on the left-hand side is our strength in our studies, and the right-hand side, and on the right-hand side, there are some limitations in our studies. First is the fewer study on PTSD from natural disaster that I have mentioned before. And second, we haven't collected the lack of the long-term efficacy data. So in our studies, most include RCT focus on the post-treatment outcome. The network did not address the sustainability of the intervention effect over time. So this could make the conclusion be limited to the short-term efficacy, and for long-term comparative effectiveness cannot be inferred. So my suggestion would be like to incorporate the studies with the follow-up outcome data into the future NMA, or to evaluate the durability of the treatment effect. And the lastly would be the heterogeneity effect. So, well, the heterogeneity is already considered in NMAs. Our study focused on the efficacy, so this may not be directly affect to our findings. But otherwise, it would be considered in traditional meta-analysis or general effect. So it's probably because the include study is significant vary regarding the disaster type and the population demographic. So this heterogeneity may confound the result as the pool analysis integrating diverse context and settings. So my suggestion would be for the suggestion to conduct the subgroup analysis or maybe the meta-aggregation or sensitivity analysis to explore more and the source of the heterogeneity between the interventions. So I'm very thank you, and I am welcoming to answer any questions. Thank you.
Thank you so much. Such an interesting topic. Does anyone need further clarification?
Thank you for your presentation. And could you please explain more how do you dealing with the heterogeneity between the study?
Okay, so as you can see from this slide, so the heterogeneity will come up with the most heterogeneity will come in CBT. As you can see, the I-square is like 99%. So, well, for the heterogeneity, we'll be focused on the traditional meta-analysis, but for my question is the network meta-analysis, which is focused on the efficacy of the intervention. So, am I dealing with the heterogeneity of the CBTs? Would be some exploring the subgroup analysis of the CBT, because we have pooling the various types of the CBT into CBT categories. So maybe for the further studies, I can doing some subgroup analysis between CBT group, and then let's see like which type of the CBT can cause the most heterogeneity effect. Or maybe doing some the sensitivity analysis or meta-aggregation for the further studies. But we haven't done it in this study yet, because our objective is focused only for the efficacy of the psychological interventions.
May I know about the outcome, because you
Yes.
show us here the standardized one. What were the original outcomes that were measured in each studies?
So the original outcome we were measuring in this study, so we have two outcomes. First is from the network meta-analysis, and the second is from the traditional meta-analysis. So as the traditional meta-analysis, the outcomes are shown as I mentioned above. So the all intervention can reduce the PTSD symptoms, but for the network meta-analysis, we focus on which intervention is highest efficacy. So EMDR and CBTs appear to be the highest efficacies compared to the other type of the interventions.
So sorry, I mean the scale of the outcome that were used before you standardized them.
Or you mean the scales of the like pooling result, right?
Before you start standardize, because different study use different scales, right? And
Yes.
therefore you use the standard.
Yeah, so most of the scale is used for aiming for treating PTSD severities, but there are a lot of these scales, but all the scale is treating in the PTSD severities. For example, like PSS scores, like PAS scores, and other type of the PTSD evaluation scales. So we have pooled this all in standardized mean difference instead of weighted mean difference.
Is it because the high heterogeneity shall it become from the unit of measurement?
Well, it's probably come from the high of the heterogeneity of the measurement, but we haven't explored the source by the outcome of the scale that could be affected to the overall heterogeneity in our studies.
Your findings that you show that EMDR is the best method for this disease, right? For the applications, so is it possible if one patient can have co-intervention about the EMDR with CBT or combined with the others?
Yeah, exactly. It's probably can be like that, like for the co-intervention in one patient, but we haven't explored the treatment effect for the co-intervention for the EMDR combined with the CBT. So this study, we only aim for the comparative of the efficacies. So we found that EMDR and CBT give us the highly significant effect. So for the further study, my suggestion would be like, if I want to explore more of the co-intervention between the EMDR and CBTs, I can conduct a new studies with the objective that aim for the efficacy of the co-intervention between the EMDR plus CBT compared to the others.
Any more questions? Thank you so much.